Good morning. I'm Amy Henry. For those of you who don't know me, I've sent a lot of emails recently to our faculty people and maybe residents and fellows as well. Good morning. On behalf of the Education Division, I wanted to welcome you to... The mic's not working? Turn it up. Okay, I'll just talk louder. Okay. So we wanted to present a little blurb this morning about both mentorship and feedback, which I think are both very important components of educational curriculum and educational programs. So I'm going to talk this morning about mentorship and the mentor program that we have at MCW, and Chris Fox is going to be talking about feedback. So thank you all for being here. So here's a dictionary definition of mentor: someone who teaches or gives help and advice to a less experienced and often younger person. I thought that was kind of cute, the often younger person, because I don't think that a mentor has to be someone that's younger, but clearly this dictionary thinks that it usually is, and maybe it usually is. So I think this is perhaps the most interesting part of my talk. I wish I could have saved it for the end, but it fit best here. This year we have a new program. We're having mentors for both the PGY1s and the PGY2s. Classically, we had just started the mentor program when you started your CA 1 year. We matched you up with a faculty. And this year we're starting it earlier to try to get the interns kind of really into our family of anesthesiology. So we sent out a survey to all the incoming CA0s and CA1s and asked them, what do you want in a mentor? What do you hope to gain out of a mentor? And these are some of the quotes. So if you might see yours up here, there are no names, it's all random, anonymous. I would like to gain a friendship in which I can openly discuss issues or questions and not feel judged. I would like to gain friendship, professional advice, knowledge, and networking skills. Perspective, advice, confidant. Best approach to starting career: how to study, how to set myself up for success, enjoyable things to do in Milwaukee. So that's what our residents, and I didn't survey the fellows, but I'm assuming if we asked our fellows, they would say something similar. And if I think about what I would want in a mentor, I think we could all agree that a lot of these things would be similar. So then I asked the faculty, what do you hope to gain from this mentorship experience? Support a fellow physician and future colleague through the challenging process of training. Being someone that residents feel comfortable talking to about anything. I like being someone they feel like they can confide in. To help keep the enthusiasm about why we do what we do and be there to help during the bumps. Influencing someone's career progress, helping someone feel like they fit into our program, and Milwaukee. So you'll notice that the two slides are very similar, and I'm glad to say that our faculty want to provide what our residents hope to gain from the mentorship experience and vice versa. So it's kind of cool. So our mentorship program, the formal statement we have in our online, hi Mike, is the mentoring program is designed to promote professional excellence through the creation of a trusted relationship. It will benefit both the mentor and the mentee. You classically think that a mentor is the mentee is just benefiting from the relationship, but I think both people really gain from it, and developing a relationship with someone like that and trusting each other can help you grow as a faculty person as well. We want the mentee to become acclimated, especially when they're first starting out, and to feel that they are an integral part of our department. And then as a support person, helping them with knowledge, helping them with clinical care, professional goals, outreach into the community, and just to be a listening ear. So residents, and again, I'm just talking about residents here because I didn't have anything to do with the fellowship matching program, although we do have them across the fellowships. Based upon career goals and interests, we matched up to faculty that were interested in becoming mentors. And I just want to say, for those faculty that are here who aren't mentors, please over the next year contact me if you would like to become one, because we're happy to involve as many people as would like to. So this important thing, I guess, residents are matched up with a person, and if over the course of the year say your career interests change or you feel like you're just not jiving with the person you were paired up with, you absolutely can change. It just needs to be approved by the chair of the Clinical Competency Committee and or the program director, Dr. Elnis. So just general expectations of a mentor. Serve as a role model, encourage an open exchange of ideas, really all those things that the residents and the mentors and mentees hope to gain from the relationship is really what a mentor should do. Help them plan their career if necessary, help them contact people in the community. Say you're a pediatric anesthesiologist and they're interested in cardiac, help them connect with someone who's in cardiac anesthesia. Be an advocate if they need it, and encourage and guide them when appropriate. So what we expect is that there's going to be a face-to-face contact with the mentor and the mentee at least 4 times a year. The Clinical Competency Committee meets regularly, and we talk about performance. And there's a letter that's created after that meeting. It's important that you guys know that that letter is only emailed to the mentor. And that's designed intentionally to try to encourage that meeting and relationship, that you guys are actually getting together, meeting, and discussing things that are important. So again, the faculty are the only ones who get that. So when you get that as a faculty person, that's your kind of note to, oh, it's time for me to meet with my mentee. And then there's a form that you'll need to complete. This is what it looks like. I've emailed this to all the mentors. So mentees, you should be seeing this as well, and you'll have to sign off on it. And you'll see the meeting checklist, things that you talk about. This is all kind of the important stuff, academic performance, the CCC letter, we can go through evaluations on resident program. You can talk about long-term goals, career plans, the created and or revised mentee's personal learning plan. If at any point residents are struggling or need help with a learning plan, the mentor is kind of the first person to meet with them and figure that out and decide that. You can, as the mentor, help them plan that, and there's a separate form that I've sent you. If you feel like that's not your forte, if you aren't sure how to guide your resident through that, Chris Fox is in our department. She's available to help with that. She's our education PhD specialist. So she's there to help with that. So the mentee, it's a two-way street. We want you to also try to develop this relationship with your mentor. Ask for help when you need it. Meet with them on a regular basis. So I had a resident as a mentee maybe 6 or 7 years ago, and I wasn't always the best about connecting with her, and it was funny, every quarter or so she'd send me an email and say, Dr. Henry, I think it's time for us to meet. And it was really good that she did that because it helped remind me in my busy life. I know we're all busy. And we would go out to dinner and I would say, pick a restaurant. And thankfully she didn't choose Eddie Martini's every time. But we went out and talked about residency and life. And then if the residents can also help make sure that that form is turned in, one of either the mentor or the mentee should turn it into the education office. Be open to feedback. Seek career and professional advice from your mentor, and like I said, if they're not someone who is a cardiac anesthesiologist, ask them to put you in touch with somebody. So the first meeting doesn't really matter where or when it is, but we encourage it to be early in the year, and we encourage the mentor to be the one to initiate that contact, and just get acquainted with one another. If you initially establish a relationship and you meet frequently, when problems arise or issues arise, it makes it easier to connect with that person. So try to have a regular meeting. So what should you talk about? Well, there's all like the business kind of stuff, and then at the end you see, I see fun stuff. So make it, like I said, make it a relationship that you establish with that person, and I don't think you're gonna hit it off with every single person and want to hang out with them weekly. But like I said, if you have a mentor, if you're as a mentee, if you have a mentor that you maybe want to switch, or someone else that you really connect with, you can definitely switch. And you don't have to have just one mentor. You can have many mentors. So I just wanted to open it up now, mostly to the faculty, I guess, and ask those of you who have been mentors, what have you done that has worked, or suggestions that you have for other maybe new mentors? I know, Lynn, you have...
One thing that could be helpful is suggest at the beginning of the year kind of a plan about how they're planning to study for exams. You know,
So at the beginning of the year, come up with a plan on how they're going to study?
and to say, okay, I'm going to do this X times a week, put this time aside, and
Yeah, I think that's
try to stick to that. And I've had mentees in the past that have had, you know, sort of like not doing as well as they'd like to on in training, and then really stick to a program like that where they do put time aside to do that, and it's improved their scores tremendously.
So I don't know if everyone at St. Joe's can hear Lynn Rusty just said, coming up with a learning plan at the beginning of the year. For example, I'm going to study this many minutes a night or this many minutes a week has helped, because then you have a goal set and you can follow through with that goal over the course of the year. Any mentees, any residents or fellows who would like to say anything about mentors or... No? Any other questions? Okay.
Certainly, some of the things that we've done over the years is both met with the mentee early on, but what I really did with them is I tried to say, okay, what do you want to do? What do you want to do with this relationship? And this is what Amy alluded to from the beginning. What does that relationship entail? What do you want to be at the end of those 3 years? Because some of my mentees, at least, I had them for 3 to 4 years. And then I can tell you the best part is I get baby pictures, I get wedding pictures 3 or 4 years later from the mentees that I had during residency, or how successful they were during. I think the hardest part as a mentor that I found is if the mentee is not doing as well, and how to nurture them and guide them to get to the point that of success. And I met as frequently as every 2 weeks for 6 months in order to create some sort of a plan for the trainee, to once quarterly in order to make the plan. So it doesn't, as Amy said, it doesn't have to be the quarterly part. It can be as often as a mentor and a mentee choose to make that relationship, and go from there.
And it doesn't have to be at a restaurant. It can be,
Cafeteria.
somewhere private, cafeteria, somewhere private. Okay, thank you. So Chris Fox is somewhere. I guess, where is she? Oh, there she is. Hi. She's going to talk about feedback. Thank you.
How do I get out of here, Greg? Do I down here? Ah, okay. Okay. So this is working? Okay. I'm Chris Fox. I've been with the department just 10 years now. It's exciting. I don't know many of you residents, so welcome to the program, and it's exciting to see you all here. So I'm going to talk a little bit about feedback today. Please stop and ask me questions if you like at any moment. That's fine. I'm trying not to cover too much redundant material, which I feel a lot of people have gotten on feedback throughout their time in training, so we'll cover just some of the big things and move on from there. So I'm going to start off today about asking you to give me some feedback. How am I doing? Fine?
I have no input yet.
Thank you, Dr. Wolk. He doesn't know how I'm doing. That's good, right? I haven't really given you much to go on, because what you're going to need to evaluate me what you think, what you can give me now is perhaps some assumptions you have based on your previous interactions with me, if they are so. You've worked with me before, you've communicated with me before. Maybe I've given you some nonverbal, some superficial communication cues. You can sort of judge how well I'm going to do. You have some presumptions of what's going on there. My personal attributes, appearance, can give you some assumptions of my performance, what it's going to be like today. And I have to all say, I'm just upset nobody said your high pony can rival Ariana Grande's, because, like, really? We're going to use that throughout here as an example as we go through. So what you can really evaluate with very little information is hardly anything, right? What you need to evaluate me to say whether I'm doing a good job or not doing a good job is some measurable common goals and objectives. So we have to sort of decide what my goal is coming in here today and what you're going to get from that, if I'm doing a good job, if I meet my goals and standards. And also some direct observation. You have to, hey, I got to get through that, right? So as educators, we're looking to make clinical assessments in a medical education situation. So we want to know what is an effective assessment, if we're doing a good job, if our trainee is doing a good job. So we have to know, we have to be able to view some actions, have to look at performance, we have to determine competence, and then knowledge base. And we have to put all those into a handy-dandy little assessment of performance. So why does feedback matter? Well, it matters to us a whole lot because it's actually important to staying accredited. ACGME pays attention. They ask not only residents, hey, are you being evaluated? Are you being evaluated in a timely fashion? Is it sufficient? Are you happy, basically? The ACGME asks us this, MECWA asks us that. They also ask the faculty, do you feel your personal performance feedback is robust? Are you getting it often enough? And on our most recent survey, you can see that it is an actual area of performance in which we are significantly lower, not only than the national mean, but it's probably one of our lowest areas of performance continuously over the years for our surveys. So we can conclude from this that both our residents and faculty are dissatisfied with the type and the frequency of feedback that they get in their training or in their teaching and along their career path. So we have to pay attention to that from a faculty development perspective and from a trainee perspective. So what's going on with feedback? Because a lot of the time I think we as evaluators, whether you're evaluating medical students or you're evaluating residents, think, hey, I'm giving a lot of feedback. I'm giving feedback, it's good. I give feedback by new innovations or resident program. But unfortunately, trainees, for the most part, don't feel that the feedback they get is sufficient, specific, timely, regular, relevant, encouraging, direct, with any recommendations or anywhere to go, or that it reciprocates in any way. So if they give you some feedback, you get some feedback, and it's a nice copacetic relationship going on. So learners tend to feel faculty don't spend enough time on their evaluations and that they base those evaluations based on direct observations. So we want to correct that feeling when we give feedback, whether it's a formative or summative feedback. But interestingly enough, it's a two-way street because trainers also don't feel that they're getting feedback, but the learners are giving them appropriate feedback. And they feel like, so there's is it a cultural impasse? Is it a generational difference? What's going on here? Well, we feel like we're giving sufficient amount of feedback and that perhaps that the trainees who want more feedback are just babies. They grew up in a generation where everybody spoon feeds them everything, etc. So we think, well, maybe learners need to be more sufficient, independent, mature. They need less guidance, more, autonomy there going on. But in the end, I think it's just kind of a combination of both things, right? We're not giving enough, but we're also not giving the right kind of feedback that's meaningful to either side of the party, either party. So, in general, most of you know this, how we evaluate. We use resident program, we use new innovations. Still just evaluation from and new innovations still exist on some of the older programs or some of the fellowships, and also some duty hours are still are being logged in there. We do in-person feedback, hopefully, maybe not enough. Some rotations have specific 360s. We have our institutional and national surveys that we do. All the surveys that come out from me, if you see my name, most of the time it's attached to a survey. I'm sorry for the 16-week survey for medication on anesthesia carts that are coming from me weekly. We do lecture evaluations and simulations. We try to pass that information back to our faculty and trainees. As trainers of medical students, you use OASIS to evaluate medical students. OASIS also kicks us a report back on resident performance from medical students annually. And then we have written communications in and outside of the evaluation system. But with all of these sort of methods of feedback that we think we have going on, hey, we have this robust program when we fill out our surveys, look at all the things we're doing, still we have this poor score on, are we giving and getting feedback? And I think, in the end, it's a little bit about learners sometimes have a hard time recognizing feedback, especially when it's embedded in teaching. They may not recall the feedback episodes going on. By the time they complete the end of the day, the end of the week, the end of the rotation, they don't remember you giving them any feedback. It was an inappropriate time, it was rushed, perhaps you didn't say, hey, I'm taking a moment to give you some feedback. So in the end, they come out of the relationship thinking or the interactions thinking, hey, I didn't get any feedback today, I didn't... and without any opportunities to inquire about specific feedback and events in detail, so they leave dissatisfied from that situation. So we sort of are identifying three types of feedback today: brief feedback, formal feedback, and major feedback. So major feedback is typically the thing that we're talking about coming from the CCC, set evaluation times where instructors and faculty have the opportunity you get formal evaluation. And then we're talking about other opportunities where there are brief feedback daily in the OR. And I'm going to give you two strategies for giving brief feedback today. And it's typically preceded by, let me give you some feedback on your performance. So I want to go a little forward here. Very simple, formative versus summative. Most of the feedback we get as trainees is in a summative form. We get it via resident program, our CCC letters, and saying, here's your score on your AKT or your in-training exam. It's written down. It says your performance, your individual performance compared to your metrics of the rest of your classmates or things not. A lot of the time, the feedback that we think of feedback is very summative, giving you very little opportunity to actually make any changes going forward, because perhaps it came 3 months after an incident occurred or something, it's the delayed factor doesn't really allow you to make improvements. So we talk a little bit more about formative feedback, which is aimed towards improving, and it's the foundation of summative evaluations. So we want to have a little more of that, but a little better summative evaluations as well. So I spent some time going through resident program, searching for feedback given by both the faculty to the residents and the residents to the faculty. So I pulled some evaluations out for you, some comments. And some feedback to residents we might see most frequently. Very solid performance this month. Yay! I mean, we would be happy with this, right? Okay, you did a good job. But not very good feedback, not a very good evaluation. It is akin to, okay, they will do well in a PEDS fellowship. Well, yay, you've done a good job. I think you could do more, so slightly better feedback, giving a little bit of more interesting. I said, I think this is the field for you. We're still kind of lacking as to why their performance is exceptional or substandard, right? I need a little bit more like, well, your high pony was on point, but your singing really sucked. Okay, I got to know why, what's good, what went on well and what didn't. So we can sort of see a little bit more along the thing as, well, this person was outstanding. They're a pleasure to work with, tremendous effort with the placenta accretia patient. Okay, good, we got a little bit further here, okay? You've done a good job, and here's why you've done a good job, but you're still missing a little bit of that whole feedback portion as what can you improve on? Or, is there something you could still do better? Etc. We want to close our feedback loops as much as possible, so not just give positive information that you think will make everybody feel good, and that's what you want in return, so that's what you're putting out there. So a little bit better feedback. might be something like this. The resident did a very nice job. They presented their patient well, had good communication skills with the surgeon, was prepared, managed the patient well. I was very pleased by their progress over the rotation and the nice job they did. So resident XY was excellent resident, trustworthy, etc. Solid work overall. So what you want to pay attention to here is not only do these people giving feedback say, okay, what did they do well, maybe what they didn't do well, compares usually typically to the expectations of the rotation and the trainee level, okay? Multiple domains are typically evaluated, not just good job. And the first two examples, they lack suggestions for improvement. And the last one, well, their suggestion for improvement is read. It's still a suggestion for improvement. It's telling you, why I feel like you have a medical knowledge deficit. Perhaps you should spend more time investing in your reading, okay? So, I mean, even if it's as simple as that, at least we've given some sort of thing where you should go from here. So, I mean, that's sort of like saying, hey, you know, Chris, your high pony's on point, but you really can't hold a tune, and you forgot the lyrics like 95% of the time, so I suggest you get some singing lessons and come back and try again next year. American Idol's out for you this year, okay? So, like, that's what we're looking for the kind of feedback we're, so not only are we addressing the problem, not just giving them a compliment or saying you really didn't do a good job, but why and how they can improve it. So, for you all evaluating in the clinical situation, as medical students, you've probably come across this 1-minute preceptor before. I'm just going to use two strategies here on discrete teaching minutes, probably 2 minutes really, on how you can give some formative feedback going forward and not take too much time out of your day, whether you're teaching medical students, whether you're teaching residents, etc. So the 1-minute preceptor is based on, it's an interoperative teaching encounter that uses 5 micro skills, which fosters assessment and acquisition of knowledge while providing just-in-time feedback. So the reason we kind of want to use this process is it, increased involvement with patients and the trainee, increased opportunities for clinical reasoning by the learners, and learners are going to get some, hey, right-in-time, concise, high-quality feedback. So the strategy here is to just get a commitment and say, hey, so what do you think is happening here in this situation? Pretty easy to sort of throw that out there. And then uncover the basis for that learner decision. Probe for supporting evidence. Why do you think that is happening? And then based on their answer, reinforce what they did well from how they responded to that question, tell them what they didn't do so well, and then teach a general principle. This is your clinical pearl, something like Dr. Ebert puts out every week. No, today we're going to come in and we're going to talk about not being a subject matter expert, it's hard for things to come off the top of my head, but this should have been done this way, go read this article and then give you a little more input on how to do this in the future. So you probably want to use this strategy during the pregnant pause or whatnot when you have an opportunity in the OR in a situation to teach with your student, not in clearly crisis situations when something has to be managed urgently, but at other times and other opportunities that present itself. But the thing about this is not a pimping opportunity. You really just want to make one strategy, one point across, okay? Don't ask the learner for more information about the case or to fill in all the gaps going forward. It's not an opportunity for the teacher in this situation to identify all the knowledge gaps, to just talk about one deficiency going forward or one thing that they can improve going forward. So on the same respect, there's this CAST model. It's very similar to the 1-minute preceptor. So you're in a situation and you have a teaching opportunity, and C is, hey, learner X, continue to do this thing. You did that really well. Change this. That probably wasn't the best decision. It was a decent decision, but maybe a better decision going forward would be this. Absolutely stop doing that. Wrong choice. Let's never do that again. And then, T, let's try this next approach next time. So there are just a couple little ways to give some feedback quickly in the clinical situation, little acronyms that maybe can help you going forward. So in general, why don't we like to give feedback? NDA adopted the term vanishing feedback in '83. It comes from the HR world. And it happens when the trainer is anxious about the impact of the feedback information on the learner. So they talk around the problem, they use indirect language, in such a way that it nullifies the statement. So we used to always come in here and say, oh, do the feedback sandwich. Positive information, what you're doing well, negative information, what you shouldn't do very well, and then end with positive information again. But ending with positive information in that sense, saying, okay, but you know, you did a good job after you've given some negative information, negates the fact that perhaps they actually didn't do such a great job and they need to make changes going forward. So we are saying, I am saying, have a continuous message. So if we say something needs to be improved, end with that. There's no problem in saying, you know, look, we can make this change for next time. That's okay. You don't need to end in saying, but you did a great job today, because then they're like, oh, yay, I did a great job today. We tend to only sort of remember selectively what we'd like to remember going forward. So we don't want to have this vanishing feedback concept going forward. And we don't want the learner to fear future negative evaluations and such that they, you know, avoid the trainer. And that was one thing when we were inputting, when we started putting together residentprogram.com, and with a concept from Kevin Jenner that said we're going to self-select our evaluators. And I said, is that not going to cause a problem with self-selecting only the people we've had positive interactions with on a day-to-day basis, because we don't want this vanishing feedback happening that, you know, okay, so like I had a difficult day, and so I am not going to ask that person to evaluate me, and probably they work with so many people they're not going to remember to evaluate me a month from now when evaluations come out. So we tend to not get the negative feedback or the most critical feedback that we need. So there's lots of research being done on how residents actively seek out, you know, evaluations from people who will reaffirm their perceptions of themselves, right? We come to the OR, our motivation for doing well on a day-to-day basis isn't always, hey, I want to improve my clinical skills and show you how awesome an anesthesiologist I am. Sometimes what we get from coming on to work is, hey, I want you to reaffirm how great a person I am. I want you to like me. I want you to feel like enjoy working with me. And in the end, that's sort of, we fail as trainers if that's what we're giving out for our feedback. So we don't want to. Our barriers in feedback to obtain data and make first-hand observations, of course, okay? You can't judge based on no information. You have to have a chance, opportunity to see it, give direct and specific feedback to those encounters that you have that are related to the goals and objectives, related to the level of trainee that you're dealing with, whether it's medical student, whether it's a resident at a CA1, intern level, whatnot. We fear retaliation. It's the thing I've most often gotten complaints about in all the years, sir. Faculty often fear that if they give constructive criticism, that they will get a negative evaluation from the resident, and that will be used for the promotion and tenure process. And I can tell you, in 10 years, I've never seen a retaliatory evaluation come in. And typically, people are very professional. They can keep that on a basis. Now, that doesn't mean negative communications perhaps don't occur, but people don't tend to put that in summative evaluations. So the fear of retaliation tends to be a little bit more in our own mind than it is in reality. And, you know, in fear of conflict. Nobody likes conflict. It's very difficult. Everyone wants to be the one that gives positive evaluations. You know, you see the residents that have, you know, 25 evaluations in a month because, you know, they are exceptional. They're doing a great job. Everybody loves them. You know, they get so many evaluations. And the ones who struggle sometimes a little bit more get less evaluations sometimes, because it is very hard to sit down and give constructive feedback in a way in which, you know, it takes more time, takes more effort. You know, you don't want to break a relationship going on there. I just have to say, you know, there's always a way to give feedback in which way that it's not hurtful to the person, and it's constructive, and it will end up growing your relationship versus weakening it. And then again, inconsistent feedback from multiple sources is tough. Whether you do that yourself, as I said, with that sort of, you know, negating anything negative you had to say with a positive at the end, or there can just be sort of a skew sometimes. Don't let the one negative, the one bad day get to you either. We all sometimes have a bad day working with someone. We get a negative evaluation, and we have one negative evaluation, and we have 100 positive evaluations, but we just focus on how my career is over because one person said something negative about me, and I'm never going to be done here. And so inconsistent feedback from multiple sources can be tough, whether you're giving it to yourself or you're sort of seeing it in your day-to-day life. But we as evaluators, and we sit on the clinical competency committee or whatnot, are looking for consistency, right? So if you have a one bad day and that's pulled out, that's not what's going to make or break you. We look for consistency in evaluations and patterns as you go forward. But
how can we help our residents not fear us retaliating in their feedbacks?
well, I will say that no one, I mean, your feedback to faculty is completely anonymous. Nobody can see it. The faculty can't. We embargo it for several months. And I'll get you, Dr. Wilk, just a second. We do embargo it, and so you hopefully by the time the faculty see it, it won't be, they won't know what month the evaluation has come from, or and unless you of course have signed it yourself. Harvey?
Yeah, there's a couple things. Part of the inconsistency that you might get in feedback may come from the fact that when you have a resident who's doing a case that may not challenge their skill level. For instance, you got a senior resident, and what do? Do you write, "Oh, excellent job placing a small IV in with wonderful vein"? I mean, right, so those sorts of things you expect at a certain level, they don't really warrant an evaluation, because as their skill level improves, you expect their challenge level to improve with it. So I think there's really a minority of cases after the first 6 months of training where you actually challenge somebody at a level where they're learning new skills or assessing new, events or whatever it might be. And so if the evaluation is at one of those things where, you're evaluating a person who is not challenged by any of the things going on during that case, it's going to meet all the criteria, and then the one time perhaps that they are challenged and should prepare but didn't, or need a procedure to be done but can't do it, or whatever it might be, but they're challenged by that. Especially if it's something that they should have done and that is not up to what their current expectation is at their level of training, then they get a bad evaluation. And so that might be the only meaningful evaluation that they get, is the bad one that says, "You had a terrible day today." Well, it's not because I got up late and made a rush. It's not whatever. It's because they finally met their challenge level and they didn't succeed, and therefore they got a bad evaluation.
I cannot disagree with you. I mean, and I would say there's a propensity towards probably average, right? And we would expect you to perform at your level, and perhaps you get into a case or situation that's difficult and you're challenged, and but as I said, I think at least at the CCC level, the committee level, when those things occur, we do pay attention to, where it occurred, if it is irregular or unexpected for the level of trainee. Okay, because I know we're going to run out of time. I pulled some feedback from the residents to the faculty that we can talk about. So when you're giving feedback to your faculty, yay, one of my favorite staff to work with. Hey, it's just as great as, Joe did a great job this month. Why are they my favorite staff to work with? Like, we also want to give them constructive feedback too. How can they improve? What's going on? What are they doing really well? What should everybody model? So here's a little bit better. Hey, my faculty was always approachable, willing to teach, let residents perform procedures. Even though I had a slight complication, I'm assuming, with my CDL, they were never confrontational, and we solved the problem together. They explained their reasoning, encouraged us to ask other staff why they do what they do, enjoyed working for them. Hey, that's awesome, right? We're not expecting you as trainees to give feedback to the faculty that says, you should go, you have a medical knowledge deficit, you really should go read up on, but we want them to have the same opportunity to say, hey, this is areas of improvement. I didn't pull negative ones, but there are a whole lot of comments about pee breaks and other such things that are in resident feedback of faculty that we could improve on. And then here, hey, this isn't obvious. I changed the name because, I don't know, hello, X-Men. But, hey, this faculty member is absolutely awesome. This is what every staff we should want to be. Incredibly skilled, intelligent, comfortable in their role as an academic anesthesiologist, knows when to step in, the right level of autonomy, who will come to you in the airways to help you evaluate the situation. He uses teachable moments, etc., etc. Enthusiasm for residents, non-confrontational teaching style. Like, hey, whoever put this evaluation in, that's awesome. I mean, who wouldn't love to get this level of detail on what I'm really doing well, or and perhaps, as I said, you're not as comfortable putting comments on what they're not doing well, but, you know, a little guideline sort of saying, you know, it is always helpful, little details. So, to just sort of wrap up what we were talking about today, good evaluations are measurable with common goals and objectives. They're directly linked to specific performance, something I saw you do. They are limited to behaviors that are remediable. Hey, if you don't like my voice or my appearance, I can't change that, right? So please don't comment on that or put those sort of things in the evaluation. They're not remediable. There's nothing I can do about that. So specific actions, specific deficits in knowledge, those sort of things, that's all well, that's all free. Please feel free to comment on my proficiency in those ways, but if I can't change it, it doesn't belong in an evaluation. So they have to be well-timed. So we're talking about those brief daily feedbacks, perhaps those 1-minute preceptors, great. Formative evaluation. Summative evaluations should come at a timely period, and I think we do a great job getting them out quarterly, or moving to 3 now quarterly, so, and et cetera, et cetera. So we want to make sure you're getting it in a timely, residents, you can access your evaluations as soon as they're complete, right? So you can go on to resident program anytime and sort of see, hey, I got an evaluation, I'm reading it, I may question it, and if you do, and we see that sometimes, like I don't agree with the perception of what happened in this case, and we might get a sort of rebuttal, and that opens a discussion. That's okay, that's good. We want to we want to hear all sides of what's going on there. And so specific decisions and actions rather than assumptions, it's a bad thing that we do, sort of assuming motive behind action. So maybe something did go wrong in the encounter, but I don't want you to assume it was because I had a medical knowledge deficit, or assume it's just because, oh, well, Chris has got all this stuff going on in her personal life, so, we're going to assume that she made this really bad decision because of that. No, we don't make assumptions. We're just going to measure your decisions and action at the time going forward and pay attention to that, okay? And then evaluations in the end have to allow time for improvement. I can come and say to you, I have noted this deficiency, and we would like you to do this the next time, but I have to actually give you time in which to change your practice going forward. So effective evaluations actually have to allow time, which is most of the time when you see a trainee who's having difficulty, their period of remediation or counseling is 3 months long. It's often enough time to sort of get it together and say, how are we going to address this and how are we going to move going forward? So we need to allow time. We can't expect that someone is going to come in the next day perfect. So some strategies. Use the word feedback. Hello, I'm going to give you some feedback today. Make sure that's timely. Don't evaluate non-performance attributes, and avoid contradictory messages. So I wouldn't end up giving some negative feedback by saying, hey, good job, and it was all awesome. So that's all I have today. Some references that you can't read, apparently. Question, Dr. Suki?